This is Healthcare Now Radio's Interviews Now. Thanks for listening in. I'm Carol Flagg, your host for today's episode. You can follow us on Twitter at HC Now Radio, and be sure to follow the conversation for this show using hashtag InterviewsNOW. In this fast-paced, ever-changing landscape we call healthcare delivery, who can we trust to tell us the good, the bad, or what's happening now? We're here to help you sort out these issues with thought leaders in the know. On this episode, we talk with Dr. Sanjay Seth, the Executive Vice President with HealthEC, a class-recognized population health management company. Our conversation today focuses on the growing attention on social determinants of health. Dr. Seth, thanks so much for joining us today.
Well, thank you so much, Carol. Nice to be back after our last session.
Yeah, that's right. We had a great conversation. That was in December last year on MIPS reporting 2018. So can you refresh our audience and tell us a little bit about yourself and what you do in your role as Executive Vice President for HealthEC?
So obviously, my role is the chief cook and bottle washer for practical purposes.
Mine too. Oh my gosh, we have that in common as well.
I think in this day and age, we have to be, flat and nimble and sort of pitch in for everything that's necessary. But HealthEC concentrates on providing support, both technology and services, for those organizations, entering this new era of value-based agreements. So, giving them all the data at their fingertips, as well as giving them some insightful questions to be raised for themselves and to their providers or for their providers. We help with both those. So technology and services for value-based programs is really what HealthEC does. And folded into that was our MIPS initiative, because it's the same providers that need to do MIPS, and give us an opportunity to build a lot more quality metrics into our platform. So it was a good undertaking for us overall.
And so we're going to be talking today, and as a population health management company, obviously this is a big initiative in healthcare, social determinants of health. The conversation that's going on right now is going on at HIMSS, and it is definitely trending. So when we say, the industry says, social determinants of health, just for the benefit of our listening audience, can you define that term for us? What does that mean exactly?
I think if you look at the classic definition of social determinants, it is general patient's profile, including how they function, what impacts their quality of life, and how they can achieve some of their own outcomes set for themselves. But in specific, it is really the social, economic, and physical environment that the patients live in and work in. That could play a significant role in them either accessing healthcare or being able to introduce behavior modifications into their lifestyle. And I think that's what social determinants traditionally means. When I talk to our providers, I make it even simpler and say anything that's not medical is social. And so we are forcing the physicians to think outside their practice walls, and that's what we think that the patients need to achieve, a holistic approach to their healthcare. So all providers are responsible for everything.
And so it's so interesting that you define it that way. It seems, I guess, to me, this sort of keen interest on this right now. Is this tied to value-based care? Is that why physicians in practices and hospitals are paying closer attention to social determinants of health? And if that is the case, what specifically is driving their interest and engagement in this now? Why now?
Under the value-based agreements, besides achieving certain quality and utilization metrics, the providers need to see the patients. They need the patients to seek care when it's appropriate, and reach out to those patients that don't seek care or they haven't seen for a while. So let's take an example. You have a patient who's diabetic. If the patient hasn't come to see the physician based on an initial recommendation by the physician to say, okay, see me after 3 months, we forget about, as providers, we forget about that patient for those 3 months until they show up again. So under value-based agreements, we have to take a more preventive approach rather than just curative. And for that, we need to reach out to the patients, not necessarily only when they come to see us. Why do we want to do that? Because overall cost of care impacts reimbursement, outcomes impact reimbursement. So addressing all the other issues that the patient may have, and this diabetic patient may not know anything about nutrition, may not know how food habits are impacting his quality of life or his diabetic status, may not have the transportation means to come to the office, may not be able to afford medications that they were prescribed, and therefore don't come back to the office because they haven't been following the physician rules. So we need to address those issues as well. How do they get to the office? How can we make medication affordable? How can we make behavior changes to the patient? So the physician, for the patient, so for the physician or the physician's office in particular, these other social issues must be addressed. And that's why social determinants of health, which anecdotally we've all known that homeless patients don't seek care, and that patients with diabetes may, be on a crash course with McDonald's, and we don't know these things. And if we don't know these things, we can't explain why they haven't had their status improved. So social determinants was always gathered anecdotally. Oh yeah, we know this patient is homeless. Oh yeah, we know this patient is alcoholic. But today we want to gather that information in a structured format so that we can correlate it with certain conditions and be able to predict that to impact care and outcomes for a particular patient, these other issues must also be addressed. So I think that's why it's becoming important. And, it's good that it's tied back into reimbursement and compensation. Otherwise, I don't think the industry would have seen this impetus to change how we gather data.
Is it too simplistic to say that sort of this interest in engagement in social determinants with regards to patients helps move care from being reactive to being a reactive sort of process to proactive?
I think it influences the delivery of proactive services a lot more than it does curative processes. So when a patient is really sick, they're going to come to the doctor, hell or high water. They'll find a way to get there. The question is, why do we want to wait for that patient to get sick to seek care? And so, yes, I think the social and economic issues, which include economic issues, impact how the patient seeks care.
And so you mentioned sort of like that the front office role in some of this. I think you touched upon that. From the physician standpoint, what role do the providers play in advocating and sustaining a value-based program that actually incorporates all these various aspects of social determinants? I mean, there's more than just you alluded to driving. Maybe they can't afford the medications. Maybe there's alcohol involved. There's obviously lots of social determinants. But what are the physicians? What is their role in this, in pushing this forward in their practice or at hospital or a clinic?
The hospitals are a different world because in hospitals we've always seen the role of a discharge coordinator or a social health worker.
Right.
And those folks always maintain a directory of community-based services that would help. It's when you take the patient out of the hospital and they're in the office, it needs to become a part of the daily activities within the office, because you can't sit with the patient and ask all these questions at one shot. Sometimes the patients are ashamed to admit their own problems. So that data needs to be extracted. I mean, no patient wants to tell you that I don't have food in my house for weeks at times, and the kids go hungry, or that no, we really don't get out in the winter because I don't have warm clothing. Those are things that don't come out automatically. So it has to be if it becomes a part of the daily activities and schedule of the office, there are many different ways of getting this data. Mrs. Jones, how come you were late today? What happened? And she's like, I don't have a way to get here. My son, who works from 9 to 5, I have to wait for him to come back for lunch to get me to the office. That might come up. Or, Mrs. Jones, why are you here 3 hours before your appointment? There's another reason for that. And so some things may not be as direct question answers. Some things need to be observed. And so that has to become a part of routine within the office. And so that there are different people at different points that may be able to gather that information and complete the assessment. So I think that's why it's important for the front desk and the nurses and the medical assistants and the phone attendants who give appointments out will get to realize that something is possible or not possible, and they need to be educated and trained to extract that data and record that data from each physician. So that's why it's important for the entire office to be engaged. But it can't be done unless the physician drives it. So if the physician starts paying attention, then everybody in the office would also going to pay attention.
Yeah. Is it, we used this word on our last conversation together, this issue of workflow. I guess this would be considered part of the workflow. It's not just the front office or the doctor or the nurse practitioner being curious. This is part of the care that they're trying to give a patient better care.
Absolutely. And as I said, it needs to become a part of their daily routine. So instead of just saying, hello to Mrs. Smith or Mrs. Jones who just walked into the office, you make that observation and ask a question, and you're looking at a screen in front of you saying that we know this about Mrs. Jones. And so as we gather more data, the social determinants analytics will tell you you have information or you don't have information on a particular patient. And yes, that needs to become a part of the registration workflow, part of the discharge workflow within the office, and a part of the workflow within the examination room. So all 3 points need to be included, in terms of all 3 points. So the employees who address these issues need to be included in both the education and training.
If you're just tuning in, you're listening to Interviews Now, and our guest today is Dr. Sanjay Seth. He's the Executive Vice President at HealthEC, and we are talking about social determinants in healthcare. So we talked about workflow training. So take us on a little bit of a roadmap here, if you could, and talk about some of the best practices or a methodology for transforming a practice so that they do pay more attention to these social determinants.
Again, there have been a couple of white papers that sort of have generalized what social and economic issues impact healthcare the most, and education, social support at home, poverty, and income inequality were all major social determinants besides race and religion. I mean, the race and religion definitely played a big role, but there are so many variations in that, whether we talk about the Jehovah Witnesses or the vegetarians or the vegans versus those that eat pork and don't eat pork. All of those also come into play. But those are like 4 or 5 things that we can pay special attention to on a regular basis. And poverty impacts housing, poverty impacts nutrition, poverty impacts access to care, all of them. So if we start with that premise, then we are able to find a solution for each one of those problems within the offices and within the social support structure in the community. So involving the community is a huge factor, whether it's Meals on Wheels for nutrition, or it is soup kitchens and food pantries, or temporary housing and shelter. They all play a big impact on the healthcare and of that individual. So having all of those community-based players engaged, involved, or available, or referable, it makes a big difference to that patient.
Yeah, and these are resources, obviously, that could be provided by a practice, readily available for information to pick up. The disparities that we're talking about here, you mentioned, poverty, ethnicity, perhaps religious issues, education. The idea, I know from a big picture standpoint, obviously, when we moved from fee-for-service to value-based care is to close that disparity gap, right?
Mm.
Right, just from a 30,000 feet up level, right? Help close that disparity gap.
Yes. And I think that, the state through its Medicaid program and the social responsibilities of some of the large health plans are beginning to play a factor or makes resources available. Within the physician's office, so far what we are finding are payers willing to fund infrastructure development and technology and accessibility are beginning to play an important role. And I think that in our most recent contract negotiations with a couple of the large payers, we were able to get their commitment for upfront dollars to help build all of these services being made available at the practice level, or at least at the organizational level to support multiple practices. And so, adding a social worker or a discharge coordinator for the organization that has this provider directory and these access to all these additional services that a practice may need is being made available. Other than that, you're left with only an alternative to fund and replicate services at every office. So a transplant coordinator at every office, a nutrition coordinator at every office. That's too expensive and uneconomical. And so we need to find, and that's why we find that creating large coalitions of providers, either formally organized as a clinically integrated network or as a group practice, some of these services that will impact their value-based programs need to be done centrally, and that's what we're trying to mimic between all our clients. Otherwise, we can talk about the workflow, but if you increase the workload, then productivity goes down, and that impacts revenue, and so then the providers become reluctant to make changes. So you got to provide enough help and resources, as well as an incentive. Hey, the better you do, the more you get rewarded. That does help, but again, it's a slow change. It's not something that can be done overnight.
And this idea of certainly from a sort of shared responsibility, right, for across providers, is you're speaking to that, and I think that certainly you see that in other countries, and I think that's that's going to be pushing some of this as well, that, that value-based care of it, but also, that shared sense of healthcare for all and for everyone, good healthcare.
Yeah, I mean, if you take all the developing countries that have provided, and there's a reason why they're called socialized medicine,
right?
is we often forget there's a budgetary aspect to socialized medicine, but there's a social aspect to that. What's going on in England and in Canada and in most of the European developing world is where there are social support systems in place, both monetary and otherwise, for everybody. And so we forget about that, all the limitations of the budget, the long wait times and all the stories we hear. But when you combine them with all the social support structure in England, if you're homeless, you certainly get put into a home. They pay for your utilities, they pay for your telephone and heat, and bus services are free and train services are free. So they find there are a whole bunch of services that sort of are separate from healthcare, but make a big difference on how healthcare is delivered. There are deficiencies in both systems. I'm not saying that one is better than the other, but they have paid a lot of attention to social determinants for a long time, not necessarily from a healthcare perspective, but as a general rule. But today that is definitely impacting both the quality and the outcomes within the healthcare system.
Yeah.
We rely on volunteer organizations, to do that, whether it's Meals on Wheels or access. And every city has a senior transportation system. But we don't see that as an organized delivery system. We just see it as bits and pieces, different cities, different states, different ways. So it's hard to pull together.
And you're right. There are pros and cons to everything, and every system. Certainly, approaching healthcare from a holistic standpoint across the board, leads you obviously to believe that the population health of your society and state and local would just be raised for everybody.
Yeah, and we see the hospitals have been doing this for a while, and because they've been under pressure not to dump homeless people on the street, and to make sure somebody accompanies the patient home, and that somebody who needs a wheelchair doesn't live on a walk up 3 stories high. I mean, those are kind of things that the hospitals have been able to have seen the need to provide. Otherwise, length of stay goes up and discharges don't occur. But in the physician's office, typically that has not been done. It's easy then to say, go to the hospital. They'll take care of all the... So you're admitting for social reasons, which is another topic altogether. But
right.
Social admissions are becoming a problem, whether it's hospice or non-hospice, skilled nursing facility or non-skilled nursing facility, or simply from the physician's office. Admissions for social reasons need to be sort of curtailed. And again, this is an approach that I think needs far more support than I think we've been able to get. But value-based contracts and giving the opportunity to physicians to make a few extra dollars that then support these kind of activities is a start. I mean, it certainly making a difference in all the organizations we've been involved with. So we've seen, I think we published a small white paper as well, which, it takes a village.
Yes.
Not something that I can expect a single physician to deliver all by themselves, but it does definitely takes a village.
Yeah. Well, and certainly the cost, I'm sure these white papers allude to it, and we're going to talk about your website in a second, but certainly, if you can, stop that, the culture of, people, going to the doctors and having health issues for social reasons, obviously that's a cost savings. The incentive program aside, that's a cost savings across the board for everybody. If you can stop that cycle.
Again, yeah, it's a place to start, and that definitely, when we did this as a pilot at one of our New Jersey clients,
Oh.
very close to Atlantic City, where multiple casinos had closed down. So
Mhm.
it really put a lot of pressure on the local health system as employees lost coverage. And they did a really appointed study of about 740 some patients, and over a few months, these patients had calculated a counted number of 1,464 interventions. You
Wow.
know, related to education, nutrition, social work, physician access, transportation. And today we're already beginning to see that these patients that were followed, what their utilization of the emergency room and other inappropriate services at inappropriate times were utilized. And we are now able to quantify that. So there's no question it has an impact. So think of it, this is a double-edged sword, right? We provided services for which there was no reimbursement, and they stopped using the services that they used to come to use. And there's a declining revenue for the hospital in one respect, and a cost to the providers for providing this. And we are hoping that these patients, through the study, that if this was over a larger population subset, that eventually the cost of care came down, and so there were bonus payments made to the institution, and that is exactly what we showed. That this organization ended up being one of the top 4 in the state in terms of quality and cost, and a $4.5 million annual impact for their 12,000 patients, that of which a significant number received these social classified services without reimbursement. So eventually they got a payoff, but it's not something that's evident immediately. We're a nation of instant gratification.
Yes, we
If we
are.
don't see
Yeah.
that, we tend to give up on these things.
Yeah. Dr. Seth, believe it or not, we are all out of time. I want to thank you so much for your time today and talking about this, critical topic.
Thank you. You're welcome. I think hopefully we'll see a lot more of these services being provided, and then gather the data to make sure that the right services are provided to the right individuals at the right time. And
right.
I'm glad I had this opportunity.
As it should be. You can learn more about Dr. Sanjay Seth and his company and the resources that they have on this topic at www.healthec.com. And be sure to follow them on Twitter at healthec_LLC. As always, we thank you listeners for tuning in today. For more information about Interviews Now, visit our show's program page on www.healthcarenowradio.com. And until next time, if it's happening in healthcare and it's now, it's on Interviews Now.